Just like to begin by taking this opportunity to welcome those who have joined us so far. We're just waiting momentarily for a few others to join us, and I appreciate the value of your time this evening and looking forward to a great engagement event. So stay tuned and we'll be starting shortly. And just testing, Jodine, is my volume coming through okay? All right. Just as we had some technical challenges for the morning today, and internet just got reinstated.
It's working well, Jerry.
Welcome, Phil. I'd just like to welcome those guests who are joining us. Just about another minute and a half until we begin the presentation, and appreciate your patience.
Well, I'll tell you, you can't fault really for the
All right, we have about 30 seconds or so before we begin. And I appreciate there's sometimes a bit of a lag when people are joining with audio, so we'll just try to do the best we can to ensure that everyone is on before we start. All right, good evening and welcome to the Grey Bruce Ontario Health Team Service Provider Board Information and Discussion Session. We understand that your time is valuable, and it is our motivation to create an engaging experience for each of you, and we wish to offer our appreciation for the privilege of your time this evening. Next slide, please. Please note that this meeting is being recorded, and as a courtesy, we'd ask that you remain in mute mode until you've been identified at the end by the moderator. As a reminder, if joining from a desktop device, meeting controls can be found at the top or bottom of your screen. If you are joining from a mobile device, please tap your screen for meeting controls to appear. Please submit any questions or comments throughout the session in the chat box and select "To Everyone" if you wish to have your comments seen by everyone in the meeting. Questions will be retained by the moderator until the presentation has concluded. In the event we are not able to respond to all questions before the conclusion of this evening session, questions will be compiled into an FAQ document and will be shared. There will be polls throughout the meeting for feedback and engagement. They will appear as a pop-up on your screen, similarly as shown in the example in the top right corner of this slide. As a reminder, as a courtesy, please remain on mute for the presentation, and if you do not wish to appear on camera, please exercise the stop video button, and once you select that, an X or a line will be placed through that. Next slide, please. At this time, I wish to offer a land acknowledgement statement. We wish to start our meeting in a good way by acknowledging the Indigenous peoples whose traditional territory we have gathered. We wish to acknowledge the long-standing history of First Nation, Inuit, and Métis people in Ontario and show respect to them today. The two First Nation communities in Grey Bruce are Chippewas of Nawash Unceded and Saugeen First Nation. We'd also like to acknowledge the many long-standing treaty relationships between Indigenous nations and Canada and recognize we all have a role to play in reconciliation. And just as a reminder, please have your audio controls in mute for the presentation. Next slide, please.
No, they wanted.
What they just said.
Okay. Okay, go there.
By way of background, the Grey Bruce Ontario Health Team full application was signed by 20 health service provider organizations. The Grey Bruce Ontario Health Team Collaboration Council is composed of members from some of those signatory organizations. A patient, client, resident, caregiver survey was launched as part of our engagement process leading to the full application. The survey asked about the state of the healthcare system in Grey Bruce, and we received 1,109 responses. The Grey Bruce Ontario Health Team will serve the geography for Bruce and Grey counties, and the inaugural year will focus on providing care to two population groups. First, improving care transitions for frail seniors, and second, supporting patients living with mental health and addictions issues. Following our submission of the full application, a ministry assessment highlighted the following strengths and opportunities for development. Specifically, the strengths included our commitment to partner across a broad range of sectors, of our long-standing collaboration across partners throughout the Grey Bruce Integrated Health Coalition, a table that has been in existence for over 25 years, and also of the self-organized primary care physician and nurse practitioner council. Some areas for opportunity include refining our implementation plan to provide greater clarity around a cohesive vision for execution of our year one implementation plan, as well as working toward maturity and to provide greater detail regarding patient, family, and caregiver engagement. It should be noted that engagement with stakeholders along the application process has been iterative and will continue throughout the life of an Ontario Health Team, and the full application was just the start. Organizations will be expected to continue to engage and participate in moving into the future with a focus on the needs of patients, clients, residents, and caregivers. The year one work plan for the Ontario Health Team is under development in anticipation of full approval by the Ministry of Health. Next slide, please.
Thanks, Jerry. Before we get into any further background information about our Grey Bruce Ontario Health Team, we want to begin by offering you your first poll, which is going to pop up on your screen as you see it there. And we want to know what sector you are representing tonight. So please take a few minutes and submit. Okay, I think we can move on. And you can see the breakdown there. Home and community care at 20%, community and social services at 3%, hospital 26%, mental health and addiction 17%, and primary care. Okay, next slide. So it's important that we sort of set the tone for what we want to accomplish in tonight's meeting with all of you. First and foremost, we want to share the path for becoming an Ontario Health Team. As you all know, we've been on this path for the last 2 years, and it's important to provide you with an update of where we're at and where we think we're going. Second, we want to shift mindsets and behaviors to realize the potential for integrated care and distributed leadership. And lastly, we want to provide all of you with an opportunity to provide input on the role and the function of the Chair's Council. And I'm going to turn it over to Michael Barrett. Next slide.
Thanks very much, Dana. And we're going to start in a place with the people that we serve. So we want to hear the voice of those people that we serve, whether it's in hospital, primary care, long-term care, community mental health and addictions. And as Jerry referenced, we did a community survey back in November of 2020, and we asked people in Grey Bruce their perception of the health system here in Grey Bruce. So this is just a sample. Some of these speech bubbles here are samples of information, feedback that we received from that survey. And as Jerry said, we received over 1,100 surveys, responses in a 2-week period. So there's a real strong interest in the healthcare system, what's going on. And again, it's demonstrated by all of you here tonight, taking time out of a lovely May evening to join our call this evening. But some of the key messages that we heard back from that survey, one is that people have challenges navigating the healthcare system. Another dominant message that we heard was people have trouble accessing primary care. So it's really important for us to hear the voice of those patients, clients, and residents. And we took that information and put it into our full application when we submitted it to the Ministry of Health back in December. Next slide, please. So what is an Ontario Health Team? And probably all of you as board members for health service provider boards know what an Ontario Health Team is. Your CEO or executive director has presented probably numerous times on the OHTs, what they are, how it's changing in the healthcare system. The way I like to describe it is that governments always are looking at the best way to structure the healthcare system. And this has happened across Ontario, across Canada, across North America, and around the world. And I don't think there's any perfect structure. We had LHINs. Prior to that, we had Ministry of Health regional offices. I think the real benefit to Ontario Health Teams today is that this puts more local decision-making in the hands of the people of Grey Bruce. So this will be Grey Bruce figuring out its direction and setting its course for the healthcare system for our geography. And that's a big difference from LHINs. You knew the size of the geography before with Ministry of Health regional offices, certainly a larger geography. This allows the providers and patients and caregivers and communities to set the course for healthcare here in Grey Bruce. Next slide, please. You may have trouble seeing this timeline, but it just shows the engagement that we've done with patients, clients, residents, families, and caregivers. So I've referenced a couple times the survey that I did back in November, getting all those survey responses back. We've also been having engagement with our patient family advisory councils in hospitals or resident councils in long-term care or client councils with community mental health and addictions. And we took that feedback and put it into our full application. We've also done ongoing engagement through our website. So we provide all the information that came back on that survey is posted in its entirety on our Grey Bruce OHT website. The second part we've done since we've done the engagement with the survey, we're also recruiting for a community council. And a community council is a 12-member council that's going to provide advice to the OHT as we move along through as it evolves and grows. And we just sought out members of the public, patients, clients, residents, families, and caregivers to see if they'd be interested in sitting on that 12-member advisory council. We actually had over 200 people respond. So again, it shows you the level of interest that we have from community providers, or not from community providers, from the public, members of the public who are interested in having some say in what their healthcare system looks like. Over the last 6 weeks, we boiled that down. We did interviews with about 28 of those 200 that submitted their names. And just today, the engagement subcommittee, we finalized the 12 that we're going to be recommending to the OHT Planning Committee. So we will have that 12-member council. The key part with this is that the 12-member council is very important, but the other folks that weren't successful in moving forward to the advisory council, we need to keep them engaged because they all have an interest. They spent the time to submit an application to the process. So we'll continue to keep them engaged. And with Zoom calls like this, it's very easy now to bring big groups together to talk about the work of the OHT. So with that, I'll pass it over to Alex.
Thanks, Michael.
Excuse me, Al.
Sure.
Alex just had a question, and sorry, it's apologies. There was an ask for introduction, and myself as Jerry Glover, I'm a member of the Collaboration Council, and Mr. Michael Barrett has just spoke. So moving forward, if we can ask the presenters to please introduce themselves as well. We have members of Ontario Health on the line helping us co-facilitate this session. So my apologies, and we'll introduce ourselves as we move forward. Thank you.
Absolutely happy to introduce myself. I'm Alex Hector, Executive Director of Residential Hospice of Grey Bruce, and also Executive Director of the Southeast Grey Community Health Center. And the next 3 slides are my turn to share some information with the audience. And I just want to say, first of all, thank you for sharing, showing interest and sharing your time with us tonight. It's vitally important. And what is also vitally important is board engagement. It's an essential component of how we form our health team. And to date, our engagement activities have been really focused around the respective CEOs and EDs giving updates to their board members. There was an opportunity to review and provide feedback in the application process. And tonight is really the beginning of a more formal engagement process. And I'm really looking forward to the discussion that's going to occur. Next slide, please. So in addition to board engagement, there are also a whole bunch of different stakeholders throughout Grey and Bruce, and we have had conversations and sought input and feedback from many that you can see on the left-hand side of this slide. But there are also opportunities for future stakeholders. We want to make sure that we're inclusive. It's not a boil the ocean situation, but we have to be very respectful of the needs of the various stakeholders. So you can just see the chat message that's popped up. So who could our future stakeholders be? And we've noted a few on the slide here, but we suspect there may be some missing. So feel free to weigh in with your thoughts and ideas on other stakeholders that should be included in the conversation as we form our Ontario Health Team. Next slide, please, Jocelyn. Thank you. So what do we want to improve? And we're really focused on timely access to care, communication across the provider organizations. It just popped up on the thing there, the justice system youth. Okay, so in response to the previous slide, thank you. What's really encouraging is the alignment between the feedback that Michael spoke about a few minutes ago from basically the population, the users of the healthcare system throughout Grey and Bruce, and the concerns that they've identified. And those concerns are really popped up and become the key focus of our year one population of our health team. So we're looking at things like improving access to primary care, reducing readmissions to hospitals, reducing the amount of time it takes to receive home care, that type of thing. There's a whole host of areas to improve, and it's really important to zero in on the ones that we think will have the most effect or the greatest impact. And this is where engagement from the boards can really help us in terms of that process. And as I said earlier, this is a really, really important step in the evolution of our health team. And I'm really, really glad to see such a great turnout tonight. And with that being said, I'll turn it over to Clark. Thank you.
Thank you, Alex. My name is Clark McFarlane. I'm the CEO of the Canadian Mental Health Association, Grey Bruce Mental Health and Addiction Services. And in terms of how we will improve, really that will be through collaboration and an increase in community leadership. So here we have two diagrams. At the top, the diagram really depicts the possible models of collaborative governance. And as you move from left to right, you have an increasing involvement of community leadership and a decrease in the involvement of administrators, as is depicted on that lower diagram as well. Also, as you move from left to right, there's a gradual increase of shared management and governance in management and governance structures. So in no way is there a predetermined destination in that process. It is a developmental process that really has and will move at the speed of trust as we work together. Over time, what we really have to do over time is decide on what makes the most sense for us in Grey Bruce, what model or variation of a model will work for us in Grey Bruce, and have that conversation. At the moment, you can see with that arrow, we are here. We are over on that left-hand side. We are collaborating with a greater amount of formality through that collaborative decision-making agreement, which provides us with, we maintain our individual board and management structures, but we also need to insert in there some connection to those structures, and that's where that Chairs Council really comes in on the governance side, where it will help align the governance of the individual partners with the OHT. So next slide, please. So this is just an overview of the overall process of the OHT development. As you can see, we started with that self-assessment, as you're probably aware, and we moved to that full application. We've had our site visit, and we are now in that developmental phase. When our full application is approved, we will become officially an OHT candidate. And as a candidate, we are eligible to become designated as an OHT. That designation will not happen until we as an OHT are ready to receive an integrated funding envelope, and the ministry is in a position to actually provide us with an integrated funding envelope. I think it's important to point out that we don't know, in that final arrow between OHT candidate and designate, we don't know what that time frame is going to be. So the ministry is still working on the intricacies of what that funding envelope would be, and we still have work to do on, as depicted in that former slide, of where we want to land in terms of our collaborative model as well. So we have that time to as a candidate, to work on that in our through our collaborative agreement. Now I'll pass it on to Al.
Thank you, Clark. My name is Al Madden, and I'm the CEO of the Southeast Grey Community Health Center. I'd like to welcome everybody tonight. It's good to have boards from across Grey Bruce involved in the first session tonight. We look forward to your continued involvement. Both Clark and Alex have made reference to a collaborative decision-making agreement, which is a critical element of the full application. As the picture depicts, collaborative decision-making agreements are provisions that enable leaders from many organizations to come together to successfully engage in deliberate, consensus-oriented collective decision-making to achieve shared goals, otherwise known as opportunities for improving patient care. Establishing effective OHT collaborative decision-making arrangements is a foundation to advancing integrated care, the levers of integrated funding, accountability structures, and integrated performance management and quality improvement measures as represented in a system balanced scorecard. Next slide, please. I'll go through some of the terminology that we're sharing with you tonight. The use of this term, collaborative decision-making agreement, also recognizes that community context differs from region to region, including provider organizations and solo practitioners in different OHTs will take different and evolving approaches to defining their roles, responsibilities, and relationships within their OHT. The intention in using this terminology is to focus on defining the mechanisms through which a foundation for collaborative decision-making can be built to support and enable progress towards a more mature state, including the delivery of integrated patient care services across Grey Bruce. Collaborative decision-making agreements are expected to evolve as the Grey Bruce OHT matures. They are to be self-determined and fit for purpose. Collaborative decision-making arrangements address resource allocation, information sharing, financial management, inter-team performance discussions, dispute resolution, conflicts of interest, transparency, identifying and measuring impacts on priority populations, quality monitoring and improvement, and expansion to more patients, services, and providers. Next slide, please. At this point in time, the reference to the Collaboration Council is a future state. The Planning Committee, of which I'm a member, is the current structure in place to facilitate the completion of the OHT application and to complete initial steps in our development. Our goal is to exercise adaptability, flexibility, responded to the needs of the communities in which we serve, and over time, the structure will evolve based on strategy. The Grey Bruce Integrated Health Coalition, identified on the left, has been in place for 25 years. The CDMA subcommittee is in place, as is the Engagement Subcommittee, to complete tasks associated with the development of our OHT. The Community Council will be in place based in early June, as Mike has talked about, based on receiving over 200 plus applications from patients, families, and caregivers from throughout Grey and Bruce. Future subcommittees may include early first-year goals, including frail seniors and mental health and addictions. The Physician and NP Council is in the early stages of forming, and the Chairs Council is a future state and fundamentally the reason that we're engaging with board leaders tonight. Next slide, please.
Good evening, everybody. I'm Jodine Goldhar, and I'm joining you today from Ontario Health. Ontario Health has been invited in by your leadership that you have heard from today to share our experience with integrated care and how that applies to Ontario Health teams in Ontario, and to help form a discussion that we want to have together tonight about what this means for Grey Bruce. I understand that this would be one of the very first times you have had a shared collaborative conversation across the leadership of your health and social care organizations and the governors. And this is exactly the kind of opportunities that Ontario Health teams bring to a more integrated health and social care system that is focused on population health and wellness in our communities. The discussions that you are having in Grey Bruce are no different than discussions that are happening all over the province. It is not unique to Ontario that we are seeing integration as the #1 lever to address what the Institute for Health Improvement refers to as the quadruple aim: the opportunity to improve the experience for clients, citizens, patients, and family members, as well as the outcome, to improve the experience for staff, and to ensure that we have value for the resources that we have. Our health and social care systems around the world were not designed to be interdependent and interconnected. In most cases, individual organizations with separate missions and visions and priorities with independent leadership and independent boards. So of course, the experience that we heard up front from people and their families in your own community is sometimes the system is not connected, or access to resources is variable and not completely equitable across the whole region. And you would be hearing this from people and families in any region in Ontario. Of course, Grey Bruce has unique needs given its geography, but so do others. And what we're starting to see is that the experience of people and their families is converging all across Ontario and around the world, and understandably why. the emphasis globally is about a more connected health and social care system. The ministry started with collaborative decision-making arrangements because one of the greatest lessons learned around the world is if you force new structures and go to legal entities or forced more structural reform, it takes a very long time until the experience and outcome for people and their families improve. And instead, the research and experience around the world shows if you start in this place, collaborative decision-making, working together around defining your shared goals and how you're going to help support your system with the kind of improvement that your team talked about today, is the way to set the foundation and learn together around how to build your collaborative relationships across organizations and across leadership. It wasn't lost on me that the way the start of this presentation happened is that the leadership from many of the organizations in your own community had shared accountability for sharing how this beginning opened. I experienced the leaders in your community as one team. And that is the entire goal of building relationships, having shared accountability and shared decision-making around the future of Grey Bruce Ontario Health Team. I have experience working internationally for the International Foundation for Integrated Care, which means luckily prior to COVID, but even during COVID, get to work with all the global communities that are doing integrated care and share lessons learned. My dogs are about to bark, I'm sorry. This is the joy of virtual work. And that learning has been distilled into some critical shifts in mindset and behavior for everybody that works in health and social care. And this is particularly relevant in Ontario, and we thought relevant for the discussion tonight. So what I'm going to do is I'm going to share some of the lessons learned globally around the shifts that need to take place in individuals, organizations, teams, and systems. And then we're going to go into breakout sessions in smaller groups and have a conversation about what this means for you in your role as a governor. And we also understand that you're going to be meeting each other for the very first time tonight. So there'll be some opportunity to get to know each other and then talk about, so what does this mean for you? And how does this impact the opportunity going forward? So let's get started. The first shift, Jocelyn, if you could please share, is that in health and social care systems around the world and policies that point to the problems in the system and blaming different parts of our health and social care system really don't work as the case for change. To build momentum, to build strength and capability is building from strength. And as the team pointed out at the very beginning, the strengths of Grey Bruce and the work you have already done together are enormous. It is unprecedented to hear from 1,100 people and their families, even before you've been designated as an Ontario Health Team. It is unprecedented to have your health and social care leadership working together as one team and sharing the vision, early thinking, and engagement around the opportunity in Grey Bruce. And we can build on those strengths. Many of you will know, if you're in the hospital sector, for instance, there may be, I've experienced this, where hospitals may say, I'm not comfortable discharging clients to the community because I don't know what happens in the community. And I maybe can't rely on community. Or if you're in primary care, you may say, I send a referral for home care, but I don't hear back and I'm not connected. Or, the list can go on. And what we have found over time is that doesn't ignite anyone around a positive movement for change, but building on our strengths does. So for instance, in Grey Bruce, you already have examples of where you've been working together, how to learn from that and to build your knowledge and your skills. And that is an incredible fundamental shift. Anytime anyone is about to blame, I like to say, let's walk a step or two in each other's footsteps, learn, seek to understand, and build from our strengths. The second is to move from transactional to relational change. We have articles that we can forward to you after this, but we did a comprehensive review of policies like OHTs, but the ones that were in Scotland, in the National Health Service, in many places around the world. And what the health and social care folks say in those countries, and the evidence will prove, that when you treat integration as a technical or a transactional piece, you don't actually move population health. An Ontario Health Team is not a project or an initiative. It is not something that has deliverables in a project charter that you move the way we might see typical initiatives. Ontario Health Teams are the fundamental shift on redesigning the way health and social care is delivered so that it is experienced through the lens of people and their families as seamless, it is equitable, and it is about full population health. And the way to do that is relational. It is about building community together, like we are doing tonight. The next is around a view from scarcity to abundance. Abundance theory is an evidence-based framework and methodology. And what we've learned from doing this work globally is when you think about individual organizations, your resources feel scarce. But if we switch it to collectively across everybody who is here in your organizations, and you imagine if you are working on your common goals together, like your two priorities, supporting older adults and people with towards support around mental health and addiction, and you start to align and leverage the current resources you have, but to work in a very different way, or to look at your budgets that you may individually have at smaller scale. And if you were to pool resources, what would that look like for impact? So it starts to shift our mindset from scarcity to abundance. If we work together, if we align and leverage our current resources, what could we make happen? I'll give you an example. In 4 Ontario Health Teams that started in the first cohort, they took an abundance lens and they started to align staff to work in the OHT who's had shared accountability across all organizations to create a backbone team. It ended up giving wings to the entire Ontario Health Team. This is above and beyond the resourcing the ministry gives and allocates. It's taking an abundance lens to how to solve for a complex change and to be able to support it. Next slide, please. This is a shift that I think will resonate strongly because I had talked about that every organization has a mission. And if you were all to map your missions out on a whiteboard together, you would start to see similarities and some differences, but you're each working towards independent missions. What happens with integrated care and Ontario Health Teams is you move towards shared purpose. Shared purpose is similar to a mission, but instead of an organization, it's working in shared purpose to meet the needs of your entire community. And you start to align and leverage your organizations to support that. For some Ontario Health Teams that were part of the first approved process, I'll give you an example. Couchiching Ontario Health Team started off with, of course, independent organizations with separate missions. Now, 2 years in or a year and a half in, they actually started organizational strategic priorities, and they have one common strategic priority across 20 organizations. So they started then aligning organizational priorities to shared purpose with the collective. That's a practical example of what that would look like. Next slide, please, Jocelyn. This happens to be one of my favorites because it resonates the most for me personally. It is traditional in traditional organizations to work hierarchically, where a few people hold the power and they direct decisions. So power is held by a few and decisions are pushed down, and it's command and control. And we look for buy-in. One of the greatest lessons learned around integrated care is an entire system, the culture, the way we work together doesn't shift through old power hierarchical ways. Instead, it shifts by building a culture of change. Sometimes it's referred to as social movement, but really it's like a current where you co-design the answers, you engage, and the change is made by many, it is spread by many, and power and decision-making is shared. So what you're starting to see already in your team today, by reaching out to the community, by working across each other, and now by bringing all the governors and leaders together, is we're looking at an open, shared process to co-design, and it's embedded in a relational approach. Very different. Sometimes it's referred to as debunking buy-in and moving to creating investors, where everybody has a say and they see themselves in the change. Now, that's not to say leadership doesn't, those informal positions of leader don't have important roles in designing strategy. Of course they do, but leadership starts to shift to convening the change process and moving the change forward, not just directing the change. Next slide, please. Which leads us to this piece, and I don't know if this is familiar to you, but moving from formal leaders to super connectors. This is not to challenge the importance of those informal leadership roles, but sometimes we miss who the social connectors are, or the super connectors. And research that has been done, and I'm happy to share the evidence, is that 3% of people influence 85% of other people in organizations and in systems. And they are not those informal roles. I'm sure, sometimes we do sessions like this in a room packed with frontline staff, managers, directors, leaders and governors, patients and families. And I'll ask people, who's the super connector in your community or in your organization? People start to raise their hands, so-and-so, so-and-so, so-and-so. And then, or people self-identify. Yet when you think about a change process, we very rarely tap those people to co-design and help influence the change we want to see. And so this is another shift, finding out who our super connectors are and engaging them as part of the process. And there are just 3 more seismic shifts. The next one is moving, and we're doing it tonight, from organizational impact to collective impact. Especially from a board perspective, you look at accountability and impact from an organizational lens. But what would it be if it shifted to the collective? How would you start to measure the kind of impact you can have if you work all together? If you name the elephants and break down the silos that exist unintentionally, despite goodwill, if you were to work together as one community focused on what's most important to people and their families, you have the exponential growth of impact. It'll be bigger than any single organization can have, and that is the move to collective impact. Part of collective impact is the next seismic shift. And this is probably one of the places we are learning to build skill and capability in the province. There are other countries around the world that are ahead of Ontario, but Ontario is in lockstep with many countries. And if you're going to remember anything, it is this slide. There's really 3 eras of engaging with patients and families, clients, and caregivers. In era 1, it is information sharing, where we say, this is our Ontario Health Team. We just want to share this information with you. That is not co-design, because the power still rests with those in health and social care. And in many cases, we say we want to engage patients, clients, caregivers, and we've already done some information and we want to get some feedback, and we decide if we incorporate it in or not. the power still rests with those that work in health and social care. Co-design is when we actually come together to solve the problem or the opportunity in partnership, so that at your leadership council and as part of the way you have a governance structure, you have patients and caregivers at the table co-designing the answers. Please move forward, Jocelyn. So I think it would be fair, this was a dear client that I worked with who shared her perspective on what is most important around co-design. Jocelyn, would you go to slide 29, please? So if we were to summarize, these are the seismic shifts. Go to the next slide, please. I'm noticing time and I want to make sure we have time. So we're talking about the fundamental shifts that have to take place for organizations and communities. And we're going to do a poll quickly. The poll is, we want you to rate, and this is anonymous, and I'm asking everybody to please participate. Where would you rate where you think Grey Bruce is right now on a continuum around the seismic shifts? Jocelyn, please go to the poll. So you're going to rate from we haven't shifted yet to somewhat, or we've already made a substantial shift. Please poll and share. We have good 26 of 56 people have responded. Keep coming in. 38 of 56. We have a couple more seconds left. If you haven't sent your poll, please do. This is a safe way to do a self-assessment on where you feel you're at as an Ontario Health team and as a community in working together, making the shifts that help shift the culture so you can create a more connected health and social care system focused on the needs of your entire populations. Okay, so you can see the results. There's variability. Does anyone want to share any comments in the chat? If you, just certain thoughts and reflections that you have with the group before we move to our breakout rooms. And our breakout rooms, you're gonna meet your colleagues, but you're also gonna reflect on, what does this mean to you? What are your reflections from seeing these shifts? And then how would that influence how you wanna go forward? So Jim, may I share? Jim has shared the integration message is terrific. So there's a lot of interest in the integration message. What about for anybody else? When you go into the chat, please press for everyone. Quick thoughts and reactions to help set the stage for when you go into your breakout rooms. Part of what we want to do is have a self-reflection. Where are we at and why? What are some of the elephants that you need to overcome, and where do you want to go as you move forward? Okay, so Joanna has put in the chat room a word template that is going to help you capture your discussion. Jocelyn, could you move? Thank you. We are going to go into breakout rooms. There's going to be 10 people in each group, and we are doing a mix across your organization. So you're really interesting for you to learn from each other and hear from each other around the conversations in your breakout rooms. The way we're going to start this conversation so we could have collective learning and build cohesion from each of the discussions is each of the facilitators will share, I guess we can call it a report back, but the general strategic themes that came out of your conversation around what resonated with you, what will enable some of the shifts, or what would you like to see. We had said to the facilitators before, sometimes the conversation just needs to go where the conversation needs to go. So if there were additional pieces that came up that you want to share, please do not hesitate. I will tap on each facilitator to share, and then as we do the report backs, please build on each other. Dana, let's start with you.
I was afraid of that. I got to tell you, we had some great discussion, and I'm probably not the best timekeeper. So my group was Doug, Mike, Yvonne, Larry, Paul, Allison, and Tina. I think I've got everybody. And we had some great discussion. And so one of the things that that certainly resonated with the group is that they actually weren't surprised to see where we were on the continuum. And really what that signaled for the group is that there's work to do. And by work, that was very nicely summarized in that we have to learn about each other's organizations. We have to gain a shared understanding of what each other's organization does, where the strengths are, where the weaknesses are, the strat plan, all of that kind of learning opportunity to really understand the different organizations that are coming together. Also, I think what was also recognized was that this number, again, was not surprising because it also speaks to the fact that this is the first time that we've gotten together. And so there's probably a level of apprehensiveness. There's probably, you know, coming from that lens of loyalty to the organization that they came from. And I think that was great that that was recognized. Just scanning my notes here. And recognizing that this is going to be, and I think this is important, a steep learning curve. Not an impossible learning curve, but a steep learning curve, that we've got lots of learning to do about each other. And I think the example that was given, that there were 20 signatories that signed and supported the go forward. And one of the members shared that, you know, I really don't know what the other 20 signatories do. I have an idea, I don't really know. And that was certainly echoed. So in terms of, you know, what will help us move forward, again, seeing each other's strat plans, weaknesses, strengths, funding, opportunities for improvement, all of those things that sort of make our organizations tick, putting that out there and being very transparent about that. I think the next thing that was, and we kind of got cut off on this, so Allison, please jump in, you know, really working on a shared vision of what is possible. And I think that is really transformative thinking, you know, moving away from that individual organization to start talking about what is the shared vision of what we can do here in Grey Bruce in our design.
Thank you so much, Dana. And, you know, I find it so interesting. Sometimes, whether an Ontario Health team is here or not, whether the government changes and there's a different vehicle for change, integration is here to stay. Because we know if we want to serve people and their families in our communities, this is the work. How do we honor our loyalty to our organizations, but how do we seek to understand, walk a step or two, and learn about each other's organizations so that you can, in fact, develop a shared vision for the future of Grey Bruce. That's incredible. Thank you so much. Jerry, on to you.
Thanks, Radine, and I have to apologize to Jane Dijon and to Carol Rencheck. We were caught up in some great conversations, and I think what was very obvious, and Dana picked up on some comments, is that we need to understand as a fundamental baseline where each other is at on our journey, and to also recognize that board governors are also patients and family members and caregivers. And while along the journey, there may be some misunderstanding about which each of us does in terms of organization. What we are trying to attempt to is to be part of a change management approach. But we also had to move from the perspective of the patient, try to view all those people at the table as a resource, whether they're board governor or patient or caregiver, to support this journey on a continuum of care. And also appreciate, you know, sometimes there's nuances and sensitivities, but to recognize that people are not trying to necessarily obstruct the change management or the process, but it's more of trying to get through the change with shared understanding in that collaborative decision-making approach. So, you know, what was really picked up on our session was that, you know, there's been some natural natural affinities or amalgamations with other legacy organizations in Grey Bruce, and those were multiple year journeys of, you know, maybe collaborating with 2 or 3 organizations. What we're trying to do essentially is to try to unravel 30 years of well-intentioned band-aids, and to try to assume that, you know, within a year or 2 that we would sort of be closer to a mature state, but recognize that there might be equal opportunity to find solutions, but working together. The poll was resounding in that, you know, more than I think 50 or 60% were not surprised by the current poll of where we are at in Grey Bruce. And I think that in part will come along with trying to understand what each organization does, what we have to offer, and really trying to understand the patient's view and whether that patient is a board governor or a patient or caregiver. So I think it's a long process is what we determined. We'll need a lot of collaboration and cooperation, because it's a heavy lifting for a shared purpose. And, you know, we will all sometimes agree to disagree, but it's ensuring that we're all rowing in the same direction. And sometimes you have to pivot left to right, but just to understand maybe a softer approach going forward. And pause sometimes is a good thing. The more people are engaged in the process and they understand the process, the less fearful of change. So I think that's what we were able to pick up from our group.
Thank you so much, Jerry. And naming the elephants, sometimes I call them the elephants. We can call them whatever that we want, but being able to bring transparently the discussions that help us break through. Like, we each bring multiple lenses. We're not just board members. We're not just sitting in a formal leadership role. We are users of the health and social care system. We are caregivers to our friends and our family. Those multiple lenses give multiple perspectives, and we have to create space to understand and have the conversations to create shared vision and break down barriers. And you also built on with the group Dana had been speaking to. So we're starting to get some common themes. Clark, how about for the group you're with?
Thank you. Yeah, so like Dana, I wasn't the greatest timekeeper, so we didn't get through everything. However, I think overall, the group was not necessarily surprised at the outcome of that poll. And I don't think the group overall was really disconcerted by it, and wasn't disheartened by it either, but rather felt we were on the right road, that there's a long way to go, that different strategies, people are obviously, it did reflect that organizations may be at different stages, different perspectives, and that we will need to employ a variety of strategies in order to bring everybody along and move things forward. But that's, you know, that's, I felt they were feeling it was certainly doable. There was certainly a suggestion that we keep it simple and stay away from the old models. So certainly a call for innovation and opening up to new ways of thinking. I guess if we were going to, if we had any elephants, I think there was, you know, it was voiced that for this particular area, it seems to be a challenge in engaging the private sector and how that private sector fits into the OHT, and we need to look at how we can do that more, be clearer on that, or more productive on that. So overall, yeah, a very good conversation. I think a very realistic one and optimistic one. So
Thank you so much, Clark. The idea of being open to new ways of doing things and not to fall into traditional patterns of change, and bringing up the innovation idea of the private sector. As you move across this, it's going to become more obvious what the opportunities are. Now, I'm conscious of time, and there's another couple of areas we have to get to, so I'm not going to do a full round, but let me ask Alex, Al, and Mike, anything that hasn't been mentioned yet that is important to share for our collective reflection?
Thanks. I'll just jump in real quick. A couple of things very quickly. we tend to remember things that don't go well, but there are a lot of things that do go well, and so we can build on them. Patient stories can keep us focused, and that's because that's what we all have in common as patients. Two elephants that got named in the meeting was whatever, no matter how hard we try to collaborate in our decision-making process, there needs to be change at the top. And we got to get realistic about money. There isn't enough. So even though we can think abundancy, healthcare is still underfunded. So those are two elephants and a couple of ideas. Thanks.
That's great. Thank you so much. How about for the other two, anything we missed to add?
I'll give you a couple of examples, Jodine.
Thanks.
On the first question, I think that we're very much aligned with Dana, Jerry, and Clark in terms of understanding the spread and responses, that we're still, there's examples of individual collaboration, but not system collaboration at this point in time. And the pandemic has really driven new ways to collaborate as well. In terms of question number two, the group felt that a bit more time is needed, that we're on the road with the establishment of the MD and NP group, and today with the establishment in reaching out to the boards as well. And that over a period of time, you know, that could lead to the formation of strategy and a shared leadership system balance scorecard that could come out of that as well. So it was good discussions, very honest perspectives, and a good breadth right across all of the groups.
That's great. Final word to Mike.
Well, Jodine, we had participants from a geriatrician to a midwife. So we had the full lifespan covered. And I think that the key message that came from our group is a number of them are new. So being new, they don't have a perspective on how well the integration is going, how well partners are working together. And I think that's a key learning for governors, is that governors, there's always a rotation of governors and not here for the extended period of time that staff would be, right? So we need to make sure that we provide governors with the opportunity to build these relationships, build the connections, get an understanding of the complete system.
Thank you so much. And Jody also shared a piece in the chat that's critically important, part of naming the elephant and the opportunity around our partners in health and social care. But there is a lot that you have to build on that has gone well. They are smaller collaborations and integrations, but you have an opportunity to build it from a system lens and to always ground it in the experience and the partnership with people and families. I always like to say the answer is with people and their families. They see things because they experience the whole health and social care system, where often those that work in it experience parts. But we have to evolve, and the role of governors is so critical in leadership. First of all, because there is change and you have to stay connected and share information, but also invest in building skill and capability. And again, this type of strategy and culture change happens at the top. So if we were to move forward to the next slide, Jocelyn, thank you. We're just going to end this session, this part of the session, with a final poll. If we were going to work on some of the shifts that are most important, which ones are most important to you? You can choose more than one.
We have a limit?
Nope. If they're all equally important, that's great too. Really just seeing what resonates most, where you think you have to focus to make the greatest impact.
I assume you created those, Jodine, and they were excellent.
Thank you for saying that. Just a way to have a conversation sometimes isn't easy to have. Okay, so let's end the poll. Thank you so much. So the biggest priority, which is exactly what the evidence and research says, if you're going to shift, you have to start with shared purpose. And that is the opportunity in front of you. And if you ask yourselves, what's within our control to change? All of this is within your control to change. It's amazing how much we can do when we work together, starting on creating a shared purpose that you all see yourselves in, and so do the colleagues that you work with, and of course, citizens and their families. So that's great. Thank you so much, and it'll be used to help guide next steps. I am so fortunate that I have had the opportunity to do this piece with you. I am grateful for letting us in and taking space with you as you do this reflective journey. And now I'd like to turn it to Clark.
You're on mute,
Clark, you're on mute.
Yeah, never learn. Okay.
It's always one person that does that in the meeting, huh?
Yeah, it wouldn't be a meeting without it. Yeah. So we do want to start a conversation in the development of the Chair's Council just regarding the terms of reference, and we are looking to co-create those terms of reference. Currently, the Chair's Council mandate reads that the role of the Chair's Council is to create a forum for board-to-board engagement of the team members. The primary objective of the Chair's Council is to ensure communication and alignment of the Collaboration Council to the work of each team member's board of directors. The Chair's Council members will act in an advisory capacity to the Collaboration Council, report back to their own boards about system and collaborative goals, and engage in communications, information sharing, and networking, consideration of strategic governance issues, shared best practices, including governance best practices, and provision of strategic advice regarding the healthcare system. So members will be expected to demonstrate fairness and a commitment to in-depth evaluation and a matter of in-depth evaluation of matters under review, and endeavor to put persons served by the OHT and the success of sustainability of the OHT above their respective organizations. So that's what's in place now, but there's lots of room to develop that, and we are looking to co-create with the board members. And with that, I will turn it over to Dana, I believe.
Thanks, Clark. I'm just going to introduce myself late in the game here. Dana House, Hanover District Hospital President and CEO. So our next steps, and this is exciting. We are looking to start the formation of our Chair's Council. So we're asking all of you to please send the name and contact information for one chair or delegate from each board to the email address there, jkehoe@gbhs.on.ca by June 1st, or June 15th, sorry, June 15th. And we are hoping to have our first meeting of the Chair's Council the third week of June. And at that time, we will be working on establishing a subcommittee to define the Chair's Council terms of reference. So the next slide is anyone have any questions or anything they'd like to share with the group as a discussion point?
And I'll just start it off, Dana, or the whole group. One question in the chat box was, how have community leaders been involved in decision-making as indicated on the graphic? And this is in reference to slide 13. It's with the progression from administrators to community leaders over time.
Yeah, so I believe that was my slide. So currently we have that planning committee, which is populated by the EDs and CEOs of the partner organizations, or most of them. And we all report back to our respective boards and take direction from our respective boards. And then that diagram is sort of just meant to indicate that progression of community leader involvement. So as we move down that with the development of the Chairs Council, for example, we will be increasing the linkage between the boards through a governance mechanism. So I'm sorry, did I capture every element of that question? Yeah.
I think so, Clark.
Thanks.
Thanks. Any other questions? If you want to put them in the chat box, I'd be happy to read them.
Jim has his hand raised.
I was just going to ask a question around the spirit of collaborative decision making. It seems that there's been a decision taken by the administrative group that we're going to have a chairs council, and that it's going to be in the model that is very much borrowed from the Mississauga Ontario Health Team. How flexible is that model and the formation of a chairs council as this subcommittee that you're forming roll out? There are other models out there, aside from the Mississauga model with a chairs council. So how much flexibility will there be in this co-design to actually co-design? Because it hasn't been co-designed so far.
I can start off if you like. So, okay. So the planning committee did land on the collaborative decision-making agreement template, and it was a template that was provided by Ontario Health. And within that, and one of the reasons we felt that agreement template was useful for us, because we felt it did reflect where we are at now. As I had mentioned in my presentation, the development and progression through those collaborative models and becoming more integrated really does move at the speed of trust. And we felt that right now it was important to have all organizations at the table as opposed to going to a sectoral approach, that it would allow us to provide us with an avenue to build that trust and to have productive conversations. So in terms of that, you know, we are working from a template. We are not, it provides us a structure and support. It doesn't necessarily define our absolute boundaries. So I think, you know, from my perspective, that invitation for co-creation is quite genuine, and it really requires that dialogue. So and that dialogue requires participation. So that's kind of where I see it.
Yeah, and I'll just add that it's truly meant to be a touchstone, but certainly to Clark's point that local needs will be facilitated, and that's very important to the co-design. And certainly things, you know, of that agreement can be talked about and reframed, etc. As a new group of chairs that are looking at this. So I think there is some structure there, because you know, I think we do need that for our purpose, but I don't want anyone to not feel that they aren't going to have a voice and that our local lens isn't going to be captured in that.
And the only reason I asked that question is based on the last 2 years of history, and that there hasn't been a lot of co-designing being done. It's been done by the administrators in somewhat of isolation, and I'm sorry, Clark, but when the CEOs report back to their boards, that's not giving the community leaders decision-making power. It is some engagement, but it's not decision-making. And so, but I very much appreciate Clark and Dana's perspective that that if this is legitimate co-design, it'll be a good process and a fruitful process, hopefully, as we move forward.
Jim, I would like to punctuate what you're saying and build some ties. So the outline was really an outline that the ministry provided to help communities think about the value of let's call it a Chairs Council. You can call it anything you want in your community. And what we've talked about tonight are some of the design principles for how you move forward. And this is an opportunity. And as Clark and Dana have mentioned, and you are compelling everyone, that this is to be co-designed so that you are an investor in the change in your own community. And that's the idea around something like this. We're also learning together, what does co-design mean, how to do it, how to raise the opportunities. And I'm hearing from both Clark and Dana that that's the opportunity moving forward. So thank you for mentioning it.
Thank you.
Yes, you're welcome. There are a couple other questions, and I know we're not going to get to everything tonight. Why don't we do one more? And this is not the only time you're going to come together. There will be more opportunities. We are going to inventory the questions that are in the chat and make sure that we respond and share it with everybody. Does that work? Dana, did you want to take one more question? No, for now. Okay, so why don't we inventory it? Oh, sorry, Dana. Okay, we're going to inventory the questions and we'll get back. Jennifer has shared in the chat that on the website there's further information about what is happening in the community related to this. Before we end, you have given such an incredible reflection on where you are at as a community and where you want to go, what the priority is, which is come together and shared purpose, co-design the future for Grey Bruce, understanding you all bring multiple lenses. Today is a point in time, but the kind of work you did tonight is the kind of work you want to spread across your entire community so people see themselves in the future of Grey Bruce Ontario Health Team and the opportunity that is in front of you. When we end, to redesign should give greater voice to the public and caregivers. Yes, yes, yes. 100%. So let's all go to the chat. If everybody could open your chat and make sure your chat function says to everyone. And if you could describe one word that either describes your experience tonight or what you see as the opportunity for the future, share it in the chat as a way to leave and share your final thoughts with everyone. Your experience tonight and your word to describe your thought for the future. This is called a snowball. Cooperation, optimistic, a good start, informative, dialogue, the importance of dialogue. Connections, educational, great experience, informative session, good beginning, very positive. A good start to community building, early days, but a great start. It was inclusive. We have potential. We're showing new perspective. Keep sharing. You're hungry, Phil, of course. Overwhelming, but excited. You can see what's possible when you come together in shared purpose. Great opportunity, need to move the needle from 5 to 10. Educational and positive. A start toward population health. Yes, it is. Super connecting. We are just starting. Embrace the change. Humbling. New ways to improve. Sedana said, uncertain about Chairs Council rules. So opportunity to do that. Inspiring session. Open-minded, looking forward to providing our expertise to further patient-centered care, subgroups first, food for thought, do it more often. To all of you, wishing you a successful, wonderful rest of the evening, renewed. Thank you for all the comments. You know, it's a way to reflect on how did we do tonight and what did it mean to you and how does it inform the path forward. We look forward to supporting you any way we can, and a huge congratulations to the board members who brought multiple perspectives and the leadership team who showed openness for co-creation and sharing the path forward together, all in name of supporting people and their families in Grey Bruce. A warm thank you to everyone and a good rest of the evening. And for the planning committee, just to stay on for a moment.